Hi, everyone, and welcome back to the studio. We're here with Dr. Inés Colmegna to welcome her into the studio and talk about her presentation, her poster presentation at the 11th annual #CArthritis event hosted by Arthritis Consumer Experts for Arthritis Broadcast Network. Just to situate our audience, this is super exciting information that Dr. Colmegna is going to bring to us. You've been a rheumatologist and working in the rheumatology community, though you only look about 12 years old, Dr. Colmegna. I know you've been in the community for a long, long time. So welcome to the studio.
Thank you so much, Cheryl. It's really a pleasure to be here with you.
Yeah, I'm going to tell the audience just a little bit about you before we dive into our conversation. So folks, Dr. Colmegna received her medical degree, completed her internal medicine and rheumatology residency training in Buenos Aires, Argentina, which is why she has that gorgeous accent. Then pursued 8 years of research training in the United States, and in 2010 moved to Canada, where she works as a clinician-scientist in the Division of Rheumatology and Research Institute of McGill University Health Center. So bienvenue. It's a bit old hat to say that now. You've been here for a long time. But you've received also 12 years of support from the Fonds de Recherche Santé Québec, Chercheurs Boursiers program. I hope I didn't mispronounce that too terribly badly. So you are really expert in a particular area of rheumatology, Dr. Colmegna. With that introduction, we'll dive right into the poster that you presented. I'm going to use all the medical jargon in the name of the poster, which you presented largely to scientists, but we're going to have you break it down a little bit further as we get into our discussion. So first, tell us a little bit about yourself and, situate yourself in rheumatology and particularly there in Quebec.
Okay, so I am a clinician scientist. A clinician scientist means that I do see patients and I do have 2 clinics per week at the McGill University Health Center. I work at the Montreal General Hospital and at the Royal Victoria Hospital. But then I also have the privilege to work in the laboratory where I direct students and I have a team of people that we work together trying to understand the questions that the patients ask me and I don't know the answers in the clinic.
Okay.
So the whys and whats and how and these very, very important questions. So that's what I do at McGill. Now, in working in the lab, I have the opportunity to not only work on a specific disease, but also in different aspects that are common or unique to different diseases. And for this particular study, we are collaborating with a person who really is the person who knows about scleroderma, who is Dr. Mary Hudson, who is a colleague of mine who works at the Jewish hospital. And for many years, we have been working together. Her is a big name in clinical scleroderma. I am just trying to help in certain aspects in the lab bench work that we are doing with her.
That's exciting. So we've interviewed Dr. Hudson before. She's amazing, and I'm sure there's a mutual huge respect and fan club going on between the two of you, both highly respected in your fields. Your poster, Dr. Colmegna, clinical features and disease phenotypes as study entry criteria for scleroderma encompass patients with significant biological heterogeneity. Okay. Break that down for us. What does that mean in English?
Okay, so if you discuss with Dr. Hudson, probably she mentioned that she's doing a unique clinical study, which is a randomized controlled trial for patients that have a condition which is called scleroderma or systemic sclerosis, using umbilical cord-derived mesenchymal stromal cells. So this is cellular therapy for people that have a disease which is very disabling and for which we don't have many therapeutic options, which is scleroderma.
Yeah.
That clinical trial was designed to test whether no mesenchymal stromal cells versus one dose versus two doses are safe in people with scleroderma, and to try to see whether there is any preliminary evidence of a therapeutic effect in patients. The total number of patients that are included in this study are 18, and the study was planned to be conducted in 3 blocks of 6 patients each. In each block, there are 2 patients that received placebo, 2 patients that received 1 dose of mesenchymal stromal cells, and 2 patients that received 2 doses of mesenchymal stromal cells. So what we have done is associated with the clinical trial. There are different samples that are obtained from patients that are participants to try to understand what, if there is an effect, what mediates that benefit, or if there is an adverse event, what is associated with that adverse event. So for the first 6 patients that participated in the study, we have samples from blood that they were obtained before they entered to the study. So this is even without any intervention.
Right.
And the question that we asked is very simple, is how different are participants in this trial that were selected using the usual clinical criteria that any study with scleroderma would use.
Got it.
We know that every patient to be part of the study needs to fulfill certain inclusion criteria and should not have anything that would exclude them to be part of the study, right?
So those would be like scleroderma as a diagnosis.
Exactly.
A certain age, a certain disease duration. Okay, got it.
Exactly. Not be very, very severely ill, because if not, there might be an imposed risk. So there are, as you said, exactly those criteria that would make a person to be able to potentially benefit from being part of the study without imposing any risk.
Right.
So those clinical criteria, everybody, of course, that is part of the study need to fulfill those criteria. But are those criteria selecting for an homogeneous group of people, or are there other things that make patients different from each other? And is it because of that many studies have not shown a global benefit, but some studies in scleroderma have shown a benefit from a subgroup of patients?
Right.
Okay? So what we did is we looked in those baseline samples from blood at cytokines. Cytokines are mediators of inflammation and mediators of cellular changes that occur in the context of different diseases. And by measuring these cytokines, we learned that there are few things that are similar across the 6 patients that were the initial participants. But there are many things that are very different from one patient to the other one, despite of the fact that all fulfill criteria to enter in the study. So what does this mean? Well, what that means is that maybe we will need to be a little bit more precise in defining who are the patients that would benefit based on not only clinical criteria, but also based on some biological markers, such as how much inflammation our patients have. Right? So that's simple. And of course, this is the first specific result that comes out from this trial. This trial is still ongoing. Over half of the patients have been recruited already. They're very interesting. We're blinded to the study, so we don't know who.
You don't know who's getting placebo, who's getting a single dose, and who's getting a double dose.
Until the study is finished, everybody has no clue.
Explain to our audience why that's sort of the highest level of rigor, as you say, in science. Explain to our audience why blinded studies are so important.
Right. So blinding is one of the methodological aspects that decrease the risk of bias in a study. Because, of course, we need to recognize that there is 30% of placebo effect. So if somebody comes to me and tells me, Inés, I'm going to give you this pill, which is going to make you feel 20 years younger, just by that speech, I will definitely have a tendency to say, okay, here we go. Yes, right? So by not knowing whether we're giving the magic pill or water, placebo, that bias of that can be introduced in different ways in a clinical study is eliminated.
Yeah, it's fascinating learning about the different ways of doing research, and this blinded process is so essential if you really want to get at what we call the truth.
Right.
You mentioned that this is a trial in scleroderma. Just very quickly, in a minute or whatever you'd like to take, just give us the Coles notes. What is scleroderma? Who gets it? When do they get it? And what does it do?
Okay. So scleroderma, the word itself comes from two words: sclero, which is stiffness, and derma, which is skin, dermis. Okay. So one of the main characteristics of patients that have scleroderma is that they do have thickening of the skin, and that thickening is because of reduction in the elasticity that is caused by fibrosis. Fibrosis is a process that is very important in everybody prevents or helps to facilitate wound healing. But when fibrosis is uncontrolled, that can lead to a lot of damage in different organs. So patients that have scleroderma have an uncontrolled fibrotic process.
Okay.
That not only affects the skin, but also can affect many other organs, for example, the lungs. And that's one of the reasons why, unfortunately, patients with scleroderma can have lung fibrosis. And that's one of the main reasons associated with a limitation in the quality of life and an increase in mortality of these patients.
Right.
Like many other autoimmune diseases, patients that have scleroderma are most commonly women. The proportion of women to males is higher than in other rheumatic diseases. And one of the initial characteristics of people that have scleroderma is something which is called Raynaud's phenomenon. So Raynaud's is essentially a vasospasm induced by cold. So what patients tell us is that when they go out in the winter or when they take ice from the refrigerator, the tips of the fingers in general become white, as if they don't have any circulation. And then after that, they become blue, and then slowly they go back to their initial state. So that's called Raynaud's, and it's one of the hallmarks of this disease, clinically. And then there are other aspects related to the presence of specific antibodies that are useful for dividing what different groups of patients that are associated with different manifestations and different prognosis and occur. So again, there are leaders in studying this disease. The person that at McGill is one of the leaders in scleroderma is Dr. Mary Hudson, but there are many other Canadians that are absolutely pioneers in the work that they are doing with patients with scleroderma.
Right. That's a great definition. I think that makes it a lot easier for folks to understand what it is. And it's interesting when you say the involvement of the lungs and the fibrosis of the lungs. The lungs seem to be implicated in other inflammatory arthritides as well, like RA, PSA, AS. So what do you think is the common thread there, or is there one?
Yes. So it's very interesting what you're asking, because for the last 4 years at McGill, we put together a group of rheumatologists and basic scientists that we are looking at different types of interstitial lung disease. Interstitial lung disease essentially is, we can equal that to fibrosis, lung fibrosis.
Right.
In people that have different autoimmune diseases. Scleroderma, rheumatoid arthritis, lupus, inflammatory myositis. And what we are trying to establish is not only what leads to fibrosis, because not every patient that has rheumatoid arthritis has lung involvement,
Right.
right? There are certain predictors of lung involvement. And it seems that lung involvement in rheumatoid arthritis, for example, has been under-recognized. But it's also important that there are different types of lung involvement depending on which the rheumatic disease we talk about. And there are different responses to treatment depending on which type of lung involvement there is. So not every patient that has pulmonary fibrosis is going to respond equally to treatment, or it's going to evolve equally during their course of their disease.
Right.
So that's what we're trying to tackle now. Why is it that in general, males with rheumatoid arthritis are more likely to have lung involvement?
So it's instead of investigating our joints across these diseases, you're doing it through the lungs. You're trying to figure out what is the common thread through the lung involvement.
So that's fascinating because we do have models, animal models, for example, that we use for studying scleroderma that allow us to look at what happens in the skin and what happens in the lungs from the same animal, right? So we are able to ask questions such as, are these two processes tied together? Are animals that have more severe lung disease the same ones that have more severe skin involvement? Are drugs that improve the skin same than those that improve the lungs, or vice versa? There are many things that we can learn there. Yeah. The same thing happens with rheumatoid arthritis. There are animal models that allow us to look at the joints and the lungs from the same animal and learn from those processes.
Amazing. I mean, we could just talk about this for a week. This would be the longest ever interview ever, but in interest of time and your time in particular, thinking about what you presented at the CRA meeting, thinking about what you took in as other research that was presented during the meeting, and the theme of the meeting was ascending to new heights, peaks of innovation in rheumatology. When you think about your own work in scleroderma research and clinical care, Dr. Colmegna, what gets you excited? What gets you up in the morning? What do you see as one of those new heights that, in particular, Canadian rheumatology has reached, but perhaps globally as well?
So I think that what gets me up in the morning is try to find solutions. And one of the key things that was discussed in this meeting was the role of cellular therapy. You probably have heard about the
CAR therapies, yes.
CAR T cells,
yeah,
and bispecific antibodies, and what we are talking now about stromal cells. So that is thinking about what we can do that we are not doing currently for our patients, and also who are the patients that really are going to benefit from these treatments, and who are the patients that require other types of solutions.
right.
So I think that that's something that was very well highlighted in the meeting, and in terms of new opportunities for treatment, specifically for patients that have very severe or refractory or manifestations of diseases that are not responding to usual therapy.
Right. I'm thinking too about the presence at the meeting of a conversation, presentations, and posters on the use of artificial intelligence in rheumatology research. How do you see artificial intelligence being used in the lab? I mean, you're doing bench work, lab work. Others are doing, really hands-on clinical work with patients and all points in between. How do you see it being applied in your area of research?
Interesting, because this morning I had lab meeting, and one of the PhD students told me that there was a presentation about a Google new machine that essentially links different types of AI and allows to come up with testable hypotheses based on the current knowledge. So he said, you know what, if this really works, you're not going to have to write any more grants.
Yeah, it's a question generator. It's a question generator. That's amazing. We're not going to do away with humans, though. I think we're an important part of that process, but that's fascinating. I'm going to have to go check that out when I'm sitting having dinner or watching the TV or something. That is just fascinating. I guess lastly, Dr. Colmegna, when you think about things you can say to a person dealing with scleroderma today that you couldn't have said a decade ago, that's promising, that's forward looking, what do you say to your patients?
I would not only talk about scleroderma, but I would talk about what I tell any of my patients, regardless of what is the condition that we are facing. It's never a good time to be sick, but it's has never been a best time than now, because we do have opportunities. So we did not have 10 years or 20 years ago. And there's also a lot more of information that allows each of my patients to become the best advocate for themselves. And there is a lot specifically here of a community approach to people that live with a chronic condition. That also is something that I don't think that I have seen that when I was training, at least in Argentina. So I really believe that the experience of a person who lives with a chronic condition can be improved and is in fact impacted by not being in isolation. So I think that's powerful, and that's something that machines cannot do, but we can.
Love that. That's given me the warm, fuzzy feeling all over. It takes a village, I think, is it's an old phrase, but I think well applied here. The feeling of camaraderie, the feeling that you're not alone, is certainly really important to most patients, if not all patients. And I think also we've seen through your leadership and others at the Canadian Rheumatology Association and the Arthritis Health Professions Association, this strong principle of partnership between clinician and patient, that you can be the smartest doc in the world, but if you can't talk to a patient, you can't connect with them, it's really hard to then help them down the path to improved health. So just huge kudos to you and all of your colleagues who recognize that. I think Canada really excels in doing training around how to improve communications with patients, and we hope this program is helpful as well. Cannot thank you enough, Dr. Colmegna, for coming into the studio with us. We know how busy you are. We've dragged you away from your lab for half an hour, and we're just very, very appreciative. And thank you for sharing your expertise and knowledge with our audience, which is largely people living with some type of arthritis, and I'm sure some who've tuned in who are living with scleroderma. So at the end, by the way, we're going to give them some links to additional information. Scleroderma Canada is in the country that offers really great information. We, of course, have information as well. Anytime you want to come onto the program to talk about your work, you are more than welcome. The door is wide open for you.
Thank you so much, Cheryl. Really, it's a unique opportunity, and thank you for taking your time to do all this.
It's my pleasure. It's my pleasure. And thanks to our audience who tuned in. There's going to be some helpful resource links at the end of this video. We hope you enjoyed our time with Dr. Inés Colmegna. Dr. Colmegna, have a lovely afternoon and evening, and we look forward to seeing you again soon.
Thank you so much. Bye-bye.
Bye for now.